I'm going to talk about what are the public health issues from sort of the view from 30,000 feet, the role of immunization, the role of other preventative measures that we can utilize, and as the comments that have already been made, Northeastern Ohio and this area we've really been in the sort of the epicenter of some of the outbreaks last year. I think you're probably aware of the fact that you're undoubtedly aware of the fact we were really at the center of the measles outbreak. That's understandable. You know that. But who would have ever guessed we would be at the epicenter of the Ebola situation in Akron, Ohio, which is really incredible. We'll touch on that. So I'm going to introduce topics of a public health nature, discuss them briefly, and then leave a few minutes for questions. Next slide. So already this morning you've heard some quotes, so it's good that I brought a quote. The most famous quote, we believe, relative to the issue of public health and infectious disease. This quote was made in 1967 and has been requoted again and again and again by infectious disease people. And now finally, after, I don't know how many years that is, but it's probably 45 years or so, some investigators have gone back and gotten the original transcript and have now found out it was never made. But the Surgeon General at that time, and it's fortunate that he never made it, because people use this to say, boy, what a ridiculous quote. And that introduces our topic. He said at that time, it's time to close the books on infectious diseases, declare the war against pestilence won, and shift national resources to such chronic problems as cancer and heart disease. That actually was never said. Next slide. And this is a picture that has been circulated, but the New Yorker magazine with a couple of investigative reporters went back, got the original transcript, that he wasn't there that day, and he made no such comments that day, but it has made for good fun to show how wrong someone can be, especially in light of everything going on in infectious disease. Next slide. So let's take a look at what the CDC said last year relative to the top health threats in 2014 and see where we've come in a year. I'm going to cover a few of these, but what immunization refusal and reluctance is certainly very important, but it's lost the top spot. And so there's a couple of simple things we can do. Simple things we can do. Number one, see that children and adults are adequately immunized. Number two, the number one point here is the problem of antibiotic resistance, which leads to untreatable infections and results in 23,000 deaths per year. That's something else that's very simple. The public has to understand that antibiotics are a non-neutral intervention. What does that mean? That means you go to the doctor, you get treated with an antibiotic and you don't need it, it causes harm. And physicians, there's a lot of pushback from physicians because they say, listen, I'm busy, I got a lot of regulation, everyone's throwing computers in front of me, everyone's making it harder for me to take care of my patients, and my patients, when I tell them they don't need antibiotics, they push back to me and say, then why did I come here? And so the problem is something that all of us share, and that is we have to take a strong stand that when antibiotics are not needed, antibiotics are not going to be used, because if they are, it results in infections with bugs for which, and I'll close with this to show you a slide on this at the end, for which there is no therapy. Mortality 50%. You probably heard of the outbreak of carbapenem-resistant enterobacteriaceae and the scopes in California. There's no treatment. So that's a substantial problem. So tell your family, tell your friends, if you don't need an antibiotic, you're good with that. You're grateful for that. It's a viral infection. One of the phrases that I've used, I have some old residents now that I've been at Akron Children's for 38 years, is that some of the residents will, I'll see from time to time, and they'll tell me of some of the things I told them. One of my most famous quotes, at least in my own mind, is I tell people when they have a non-bacterial infection, we'll tell them, if I treat you with antibiotics, you'll probably get better in 7 days. If I don't, you'll probably get better in a week. And after a few minutes, they kind of figure it out. Now we can say, I'm going to, as of here and now, on Public Health Week, I'm going to change that. If I treat you with antibiotics, you'll probably get better in 2 weeks. If I don't, you'll probably get better in 1. So that's on the fly, making up a new comment. Drug abuse, global health security, such as the outbreak of measles. We're going to talk a lot about that. HPV and preventing cancer with vaccination, and even polio. 2 of the diseases that were targeted for eradication from the world, polio and measles, were actually sliding backwards in the world. Hard to imagine. Next one. So all the antibiotic resistance, it results in a lot of different infections, but the biggest one that you're going to see, which is such a great health threat, is Clostridium difficile. I'm just going to show you one slide from the CDC that really tells the story. We talk a lot in public health about infection control procedures. Here's a major hospital where they were having an outbreak of Clostridium difficile. This is the number of cases in blue bars. They implemented strict infection control measures at this time in 2003, and what you see is things did not get better, they got worse. It was only when they started to restrict antibiotic use. In other words, we now have a committee where they have the authority to go in, and I've written a prescription for an antibiotic, and the antibiotic stewardship committee will go in and say, that antibiotic is not necessary. Can be told. They can even have the authority to discontinue another doctor's order because that antibiotic is not needed. Extraordinary measures are needed right now. That's how difficult the Clostridium difficile outbreak is in America. Next slide. Why is it such a major outbreak? It's because we have a new strain of C. diff. It's called the epidemic strain. I'm not going to go through all this, but I'll drop down to one of the bottom bullets, and that is the problem is this strain makes much more toxin than the strain that was present 20 years ago. So the symptoms are much more severe. People are dying from this. People are having their colons removed because of this. And it can take much longer to respond to treatment, and treatment can be much more difficult. Treatment is so difficult and unsuccessful at times that this is a circumstance where the most important article in infectious disease in the last 2 years was the fact that for now, just to give you an idea of how important no antibiotics can be, people with C. diff that are not responding, the treatment that is used is a fecal transplant. Frequently for an adult, the spouse donates feces. They're given by NG tube or by capsule in some places, and that restores the gut flora, and that's what it takes in order to turn this Clostridium difficile off. Extraordinary measures for antibiotic use where it's not needed. That's one of the major messages I want to make. Next slide. There's outbreaks in other areas as well. I won't cover these, but just to get back to the Surgeon General comment, infectious disease outbreaks are gone. We now have a variety of respiratory illnesses, SARS, MERS, Ebola, chikungunya, and dengue I'll put in with the same, and then the much more virulent and deadly bird flu. A lot of those are in other countries, and one of the other messages I have, so number one, antibiotics only when necessary. Number two, the most important thing you people can do, in my mind, and I'm going to show you with my last slide a case that was just discharged a couple days ago that was on the news in Cleveland and in Akron, and the most important thing you can do is get a good history. A good history is worth 3 physical exams in my mind. Know where the patient's been, what the background is, what the exposure is. That's going to be most helpful. In the doctor's offices, For Akron Children's now, one of the things we've instituted in the last year, before the patient gets past the front door, we want to know where have you traveled to. Because these things, some of these are in the United States. Congeni and dengue are actually in parts of Florida now. But those are major issues that time doesn't permit me to cover. Next slide. Let's talk about measles, because that is something that I know a little bit about. When we look back over the last 20 or 30 years, what we did was we thought we were very close to having measles eliminated. And then we ran into this little problem, vaccine refusal, or as some people call it, vaccine hesitancy. Some of the parents that we see, they'll get immunized, but on their terms, according to their schedule. And the child is susceptible for a longer period of time. And in part because of that, what we saw is measles starting to come back, and then in 2014, the outbreak around America, and especially in north central Ohio, was much worse than we ever expected. Next slide. So why was there an outbreak? Why is there still substantial circulation? I think vaccine hesitancy continues, but it's not the only thing. I think that there are some things that we're learning relative to immunization that I'll mention. More cases in the U.S. in 2014 than any year in the last 2 decades. Next slide. Why? So what are the factors that make the measles prevention so important? Number one, it's one of the most contagious vaccine-preventable diseases that there is. I would say chickenpox is more contagious, but after that, measles would be as contagious as you can see. Reproduction rate, 12 to 18. In other words, when you have someone with measles, on average, they will infect an additional 12 to 18 people. Number two, there's a herd immunity threshold, and depending on the communicability of the disease, what number of cases are clinically inapparent, etc. You need to have immunization at a certain level to ensure herd immunity. And that immunity level needed to interrupt transmission. You need to have 92 to 94% of your population immune. Now, when you look in certain areas and pockets of people, you're going to find that under the best of circumstances, I would say in the United States right now, we're at about 90% compliance with the recommendations, approximately 90%. In some places in north central Ohio, I would say we're lower than that. So it's just not going to be a surprise that there's an outbreak. Every measles case, like chickenpox, there's no such thing as a subclinical case. In other words, if you have measles, you're sick. You have rash. Now, having said that, same thing for chickenpox. Because of that, we can track disease better, but there's another problem that we never expected. And the other problem is there's only a few people as old as me still practicing medicine. And consequently, a lot of people have never seen measles. They don't know, they can't recognize measles, and so there's a lot of confusion out there. I had a case of chickenpox a few years ago. It was an unbelievable occurrence. I wanted to get a biopsy on this child, and we talked to the dermatologist, and she said she had never seen a case of chickenpox. So it's just, that's through no fault of their own, it's just that it hasn't been seen. Complications are common, 0.2 to 0.3% case fatality rate. In 2012, 122,000 children died in the world from measles. In 2014, hundreds and thousands of cases when you go across Europe, when you go to places like Pakistan and the Far East, there's thousands of cases. It's unbelievable. So, from a public health standpoint, again, antibiotics when they're not needed, we're not going to use them. Number two, a history is better than anything else. So if someone has a travel history, especially an international travel history, that has to alert you, I need to step back and take a complete look at what's going on here. Some of these other diseases are much more common, and the outbreak in north central Ohio was really related to international travel. Next slide. Incidentally, I saw 3 cases of measles last year that were in the hospital. 2 of the children I took care of, one was in ICU for a prolonged period of time and almost died. It's extraordinary. For the people who haven't seen it, their comment is, I never thought it was that severe. Measles is really, the other thing, it's an indicator for the weakness of an immunization program. If you're seeing measles, your patients are not adequately immunized. Measles harms not only the individual but the community. We need to do a better job at immunizing. We need to support efforts on an international level to eradicate measles. And measles meets the biologic criteria for eradication. No subclinical cases. No one's going to have measles and be undetected. So that makes it an ideal disease for eradication. That's why we thought we were close to eradication 15 years ago. Next slide. This is typical measles, a ret or erythematous maculopapular rat. I'll make a couple comments about recognizing measles. When doctors talk to me on the phone, that's really what I do all day long. My wife wants to know. I talk to people on the phone like a teenager. And basically the first thing I want to know is, was there exposure or travel? Number 1, really, are they adequately immunized? If they had 2 doses of vaccine, I would like to tell you that it's 100% sure they can't get it. That's one thing we learned about the last measles outbreak in 14. There were some people, a few people, who had 2 doses of vaccine and got infected. Very few. The vaccine is better than 95% effective. Better than that. We actually had one person in New York City who infected 11 other people, and he was referred to as Measles Mary. The interesting thing about him, normally when you're immune, we draw blood, and the only thing is if you get a subclinical boost, you may see an IgG response. This guy had an IgM response as if his body had never seen measles before. That's what was so peculiar. 1 dose of vaccine, not nearly as good as 95+%. Question 1, are they immunized? Question 2, if it's a child under 9 months, was the mother immunized? Question 3, were they born before 57? If they were, they almost surely can't get it. We've always said you can't possibly get it. I was born before 57, and what we've seen in the United States in the last year is that there were some cases in some people born before 57, and so both my partners and I, he took the role of getting, just updating his vaccine, and I went out and got a blood test and found that I was still immune, having been born before 57. Number 4, whatever number I'm up to, you can see red eyes. The 3 C's of measles: cough, conjunctivitis, red eyes, and coryza, a runny nose. They need to, the prodrome of cough, I can make the diagnosis sometimes from down the hall. It's a very characteristic cough, and they have to have cough to have measles. Quarantine the child. If you think the child has measles and you're a doctor and someone calls and you're wondering about that, I think what you need to do is say, come in at the end of the day when all my patients are gone. And then if you make the diagnosis, you need to keep the patient at home until public health arrangements can be made. That isn't always done. Some of the major outbreaks have been the doctor gets a call and he says, I'm not there, why don't you go to the ER? What's the worst place to send a patient? To the ER. Make other arrangements. And prevention. Remember, this is a disease where vaccine within 72 hours can be very helpful, and gamma globulin will protect. So we have some modalities. Next slide. I want to cover. I want to watch my time because I get a little passionate about this. Another big change you're going to see now in the next, it's already happened, is more prevention of meningococcal disease. So, you know there are 5 strains of meningococcus that causes meningitis. And up until now, the most important discovery in the last 50 years is what? It's been the conjugate vaccine technology. It's not the computer. It's not the iPad, it's conjugate vaccines for Haemophilus, strep pneumo, and meningococcus. So we now have conjugate vaccines for meningococcus, but we don't have a vaccine for B up until now. We can cover A, which is in Africa, C and Y, which are in America, and W, which is in the Middle East. So now the CDC and FDA said we will recommend infant immunization with conjugate meningococcal vaccine if the child is at high risk for meningococcal disease, sickle cell patients and so forth. Okay? Next slide. What's the new news? Well, the problem is now that there's so little meningococcal disease, we have to immunize. This is a public health term, NNV, number needed to vaccinate in order to prevent one death. Now, in the low incidence era, we need to immunize 614,000 infants in order, 642,000 infants in order to prevent one death. So the number needed to vaccinate is going up. The low-hanging fruit is gone. Now the problem's getting worse to make a decision, immunize or not. Next slide. So here's meningococcal disease next. Here's the change. For 40 years, 30 years, when I was a fellow in Cleveland, we were all working together to try and figure out for Haemophilus, for strep pneumo, for meninge, how do we get a vaccine that works? We were taking the capsule and injecting the capsule into babies, and it didn't work. 10 to 15 years later, someone came along and said, let's take the capsule and hook it up with a nonsense carrier protein, and it works. It works in babies. They get lifelong immunity. It's boostable. What a vaccine. That's better than computers. It saves more lives. But we don't have a meningococcal B vaccine. Why? Because the capsule of meningococcus B cross-reacts with certain parts of our brain, form antibody to the capsule, form antibody to the brain. We need a new approach. Next slide. And here's the new approach. Here's the schematic of meninge B, and you can see it has little structures coming out called outer membrane proteins that bind to parts of complement, which is how we defend against meninge. And now what we've decided to do, we as medical community, is we're going to immunize with using outer membrane proteins, not the capsule, in order to prevent B. Should we be using that vaccine? So B is not preventable. It's in pink. C and Y are in the US and preventable with the old vaccine. What you can see now is what we have left in America. It's about 50-50. Close to half of the isolates in the US that cause meningococcal meningitis are serogroup B. The other half are strains in the vaccine. So now that we have a B vaccine, you immunize against these. Should we be immunizing everyone as an adolescent against B? That's the question you're going to have to answer. The problem is the vaccine has come to the market. There's two vaccines, Trememba and the Vixero. And those vaccines, it's a 3-dose regimen. They're painful, and we don't know how long it's going to last. The FDA rushed this through production. Why? Because of an unmet need. Next slide. Next. Because there's outbreaks in major universities. Does anyone know what this university one is? An outbreak of meningococcal B disease? Ohio University. And now there's been outbreaks on the East Coast in the Princeton Drexel area. You can see University of California, Santa Barbara, Oregon State University. They've had 6 cases, including a death. So now meningococcal B is present. What are we going to do? You're going to have to make a decision whether or not to immunize. Next, okay, Ebola. This is the area of West Africa that's been most affected. Next, and you can see here, next slide, one more, this is a classic example of an outbreak or epidemic, looking at the number. You know that one of the nurses who cared for the patient in Dallas actually is from Akron, came to Akron, and a number of people were potentially exposed. I just, again, want to emphasize the idea that the number one thing in our arsenal in this regard is getting a good history. Infected people are not contagious until onset of symptoms. Infectiousness of body fluids increases as the patient becomes ill. Human-to-human transmission via inhalation has not reliably been demonstrated. Next slide. Bleeding from orifices is obviously a telltale sign. Interesting, we have not seen any cases of Ebola in Akron, but we had a case 2 years ago that we considered Ebola. A patient, a foreign, one of our problems in northeastern Ohio is we have a lot of universities, and a lot of universities, they care for students and that are international students, and then we get the students when they get sick, and frequently that increases our level of needing to be familiar with a lot of different diseases. A young patient came into our hospital who was bleeding from orifices and had come from Africa, and yet the timing wasn't good for a hemorrhagic viral disease, but we were concerned, and actually what we found out, and it took us some substantial period of time, so we actually had a dry run for Ebola before we had the real run for Ebola, is that that patient had ingested rat poison as a suicide gesture, and that's the mechanism of action of rat poison. So it's just very difficult. Next slide. You've heard a lot about this from the West Coast, carbapenem-resistant enterobacteriaceae, CRE. Those are gram-negative infections like Klebsiella, E. coli, etc., that are found in the gut. People who've gotten antibiotics, then the carbapenems are drugs like meropenem, imipenem, that we rely on to treat these patients, but if they've had a lot of antibiotics, they can develop resistance to carbapenems, then frequently no drugs are left to treat them. What I want you to know, these healthy people, staying healthy is the best way not to get this. Not being on antibiotics is the best way not to get this. Patients who have devices in, various lines, ventilators, catheters, etc., long-term antibiotics are most at risk for CRE. These infections are difficult to treat with mortality rates approaching 50%. Next slide. Final patient I'll show you here, which is, I think, just a classic situation from the public health standpoint, where a person like me interfaces with public health, and you know, it's just really timely. I've been doing this for 38 years. People like my wife wonder when I'll retire. She's not anxious for me to retire. I've been at this for 38 years and I still love it. And I don't know how long physically I can go, but many more cases like this might be a problem. But this child came in. I'm not sure you can see it with all the lights on. As I step back, I don't know if you can see, the child came in with cough and fever to our emergency room a couple of weeks ago. And this child has what looks like a cavity here. And the radiologist read that, and because it's so unusual, again, it's not just doctors who do what I do, it's even the radiologists have never seen a lot of these things. So they see a cavity like this, and they think that it's staph. Staph can do something like that, but not really. This is a little girl who had immigrated from another country about 4 years ago, and part of the history, again, a history is worth 2, 3, 4 CAT scans, 2 physical exams. Get a good history. And she had immigrated to another part of America, and she had a positive skin test, got placed on isoniazid, and obviously the isoniazid failed. She now comes in with a cavity. This is not staph, but in a foreign-born person from a highly endemic area, this is TB until proven otherwise. Not only that, this is a child, but this is adult-type TB with a cavity. Therefore, she's contagious. And likely, since she had isoniazid, She has INH resistant or multi-drug resistant TB. Limited number of drugs to treat this. So we got the isolation right. Next slide, last slide. We got the CAT scan to demonstrate their surrounding pneumonia, but this is a definite cavity that looks like TB. And our good job in a case like this, and you're talking about, you gave out a lot of recognition, which is great. Our nursing staff and residents and so forth, they're taking care of this patient, and it's really kind of amazing. We need the bug, because if we don't know what the bug is, I don't know what to treat with. And so the problem is not making the diagnosis. The problem is what's going to kill this bug. So now you see some of the problems we face under these kind of circumstances. We have identified the bug both by PCR and by, she couldn't bring up sputum. That's one of the problems. We drop nasogastric tubes in the morning to aspirate the stomach contents. We're pretty confident based on some of our samples we will be able to grow the bug. But we started the patient on therapy. She's now home under quarantine. But these are some of the challenges that I think we came across the diagnosis within a matter of a couple of hours. But in cases like this, history is critical. Refusing antibiotics when not necessary, critical. Seeing that everyone is immunized, critical, because we've already reached our threshold with a good deal of outbreak. And the final point is, the low-hanging fruit we've already picked. Now the decisions are going to be difficult. Are you going to start immunizing people as they go off to college with the meningococcal vaccine? That's going to be a difficult decision for you. I'll stop there, and we'll have time for a question or two? Yeah, all right, very good. Any questions? Did these guys hear this talk before? I think they must have. Yeah.
What is the law in the state of Ohio as far as requiring immunization for public education?
I'm going to tell you what I think. Maybe some of the folks here, they would probably know more than they would know more than me about that. As I understand it, Ohio is one of the states that will permit school attendance for philosophical reasons, not just religious reasons. That's how I would answer the question. How would you answer that?
Yeah, that's correct. Yeah.
That's correct. So as I understand it, it's somewhat lax, to be very honest. Anything else? Yeah.
With respect to overuse of antibiotics, is there any school of thought on the use of antibiotics preoperatively in terms of cutting back on that as a means to
I think we have been pretty good with that. We now limit it to 1 dose or 1 or 2 doses, and in addition, as an alternative, we're doing more with decolonization of the skin with various powerful soaps and so forth. Yeah.